So the role of surgery for a newly diagnosed patient will often depend on a few factors. One is, of course, whether the tumor is localized to the kidney alone. So if we see that the tumor is only present in the kidney, that's number one. Number two, we think about the size and the location of the tumor. Is it a complex operation? Is it a simple operation? Does the whole kidney need to be removed? Does part of the kidney need to be removed? And the third factor, of course, is we think about is the patient themselves. Are they old? Are they healthy? Are they young? Are they fit? These are all factors that go into our decision making in terms of whether we would recommend surgery for kidney cancer. A new patient can find a skilled surgeon for a kidney mass through a variety of factors. One, of course, is asking their primary care doctor who they might recommend, because some of them, although kidney cancer is rare, it's not super rare. And a lot of primary care physicians have established relationships with urologists and urologic oncologists. The second way is to, of course, look at the major medical centers in the town that you live in. Many of those cities will have a central academic center, and those practices will often have urologic oncologists associated with them. And of course, there are resources such as KidneyCAN and others that can provide additional names of specialty providers. The difference between a surgeon and a urologic oncologist comes down to training and focus of their practice. Most urologists in their training have learned how to do cancer operations at some point or another. But most urologists only do a small part of their practice as cancer surgery. Urologic oncologists, on the other hand, have had additional training after their residency, typically in a fellowship where they would focus on cancer operations. Most of urologic oncologists, when they get out into practice, will retain a predominantly cancer-focused surgical practice, which means that they are mostly operating on patients that have cancer. And even further, urologic oncologists can specialize even on one organ, for example, and those are the most specialized. Surgery is not always the first step for a patient with newly diagnosed kidney mass or cancer. Surgery can play an important role, but as I mentioned earlier, certain factors may suggest other treatment strategies. For example, if a patient has a very advanced kidney cancer, unfortunately, with a mass in their kidney, but other sites of disease, often we will refer those patients to a medical oncologist to be treated beforehand, and then they may end up coming back for surgery later. Second scenario where surgery may not be indicated is if the patient is not well, medically speaking, meaning they have other medical issues or they're very old. Some of those patients may be just simply watched and we would never have to intervene. And other patients may be very high risk for surgery. They've had a lot of operations. They have a very weak heart, for example. And those patients we might refer for other treatment strategies, such as ablation or radiation. Traditional laparoscopic surgery, or now more commonly robotic surgery, has allowed for certain advances to occur in the surgical field. They are not superior in the sense that they do not offer better cancer control rates. And if anything, there is some suggestion occasionally that robotic or laparoscopic surgery can be associated with atypical patterns of recurrences. But for the most part, robotic and laparoscopic surgery mimic the approach and strategies of open surgery, but offer a smaller incision and a little bit faster recovery period for patients, and maybe some less blood loss. The difference between a partial and radical nephrectomy is basically what is left behind following the surgery. A partial nephrectomy simply means that we take out part of the kidney, which is typically the area where the mass is residing. We usually will take out a little piece of normal kidney along with the mass to get what's called a negative margin. Margin referring to the amount of tissue that's healthy that's removed along with the kidney mass, so that we can ensure that all the mass has been removed safely. The reason why we try a partial nephrectomy is, of course, because many times the kidney tumors are small or located on the outside of the kidney, and the rest of the kidney is healthy and does not have tumor or disease in it, in which case we don't want to sacrifice the value and health of the kidney to control a cancer. There is no benefit that we've ever shown in the last 30 or 40 years that taking out more kidney will help control the cancer better. If the cancer is shown to be growing into the vena cava, which is a large blood vessel that returns blood to the heart, or the lymph nodes, which is around the kidney, that makes surgery itself a little bit more dangerous and potentially challenging. We have to account for the fact that that might also be a sign of a very aggressive disease. And that is a scenario we want to make sure the patient has adequate imaging. That is imaging of the whole body, typically the chest, sometimes the brain, sometimes the bones, depending on symptoms. And that allows us to make sure that we're not dealing with a scenario where the patient has advancing disease rapidly, because we don't want to go in for surgery in that context. Those patients are generally better served with medicine. If the tumor is restricted only to those areas, then often we will operate, but the patients are often made aware that A, the surgery can be more risky, could be in the hospital for longer, and B, they're likely going to need additional treatment down the road because surgery is often only part of their treatment plan. There are lots of doctors that can take out kidney tumors. And I think it's important to go to someone, however, that sees cancer patients on a regular basis. Surgery can go quite well, but it can also have complications. And complex tumors require surgeons that have a lot of experience because there are scenarios where surgery can violate surgical principles, cancer principles, where tumors might be spilled or might be crushed, which case cancers can spread in ways that we would not predict them to otherwise do. Also, if a surgeon in one hospital that's very experienced might recommend a partial, and a surgeon who's not very experienced might recommend a radical nephrectomy, that's an important distinction and often can lead to adverse outcomes in terms of kidney function. So that's a very important decision to make. So I do recommend that patients seek out surgeons that are very experienced, and often you should feel comfortable asking your surgeon if this is something they perform routinely. Second opinions are often recommended for patients that have any sort of major surgery that they're undertaking. In fact, I encourage my patients to seek out second opinions whenever they ask me about it. I think a second opinion can often be important for kidney tumors, especially when there's some ambiguity about what makes sense to do. And I think getting second opinions can often help patients get clarity about their initial choice. Occasionally, it can produce more ambiguity, especially if the second surgeon recommends something very different than the first. And often they'll need a third surgeon to be the adjudicator there. But I do encourage patients not to go down a rabbit hole of seeking many, many opinions, because that often just delays the inevitable. But I do think it's important to seek a second opinion, and especially if you're in a location where there's not a lot of high volume surgeons, even if you like the surgeon that you've met, it is important to seek a second opinion just to make sure that you are getting the right opinion in terms of how to manage that kidney tumor. One common scenario that patients will often ask me about is how long they have to stop treatment if they're going to undergo surgery, whether it's in the primary tumor or in another site, and when they can resume treatment. Each treatment that is offered has a different window of time that it's in the body, some of which can be very rapidly cleared, and others take a little bit longer. In general, however, patients need to hold treatment for about a week or a week and a half before they undergo surgery. Following surgery, they can often resume treatment within about 2 to 3 weeks. This, of course, depends on their overall recovery and whether they have any complications or any issues with wound healing. But in general, patients are able to resume treatment fairly quickly. There is often some anxiety about holding treatment to have surgery, but in our experience and many other published experiences, this is a safe approach and has not shown to lead to adverse outcomes.